Yes, sir. Start, please.
Rigid nails. It is the article, sir. Introduction. Tibial fractures are the third most common fracture site in pediatric patients under 16 years. Non-operative management using closed methods and cast immobilization is usually the treatment of choice for closed minimally displaced fractures. Internal fixation has become increasingly popular as operative treatment of pediatric fracture is increasing in general. In a recent study, Stenrus et al. Stated that 1 in the 3 pediatric shaft fractures are surgically treated. Elastic nailing is preferred in surgically stabilized of pediatric shaft fractures because of the low risk of infection. Because the low risk of infection, it allows early mobilization and does not cross the physis. Several studies have shown that good outcome with flexible intramedullary nailing. However, possible complications using the technique include axial deviation and delayed union. The lack of rigidity of flexible nailing is associated with a high risk of malunion in older and heavier children. There is very limited data on rigid intramedullary nailing in the pediatric population. It has been generally contraindicated to use rigid intramedullary nailing across the open proximal tibial physis, except at the end of the growth period because of the concern about growth disturbances. Our aim was to describe the pediatric patient population undergoing rigid intramedullary nailing and to compare its surgical outcome with those of children receiving elastic intramedullary nailing. The hypothesis was that younger and more lighter children with displaced tibial fractures are more often receiving elastic intramedullary nails, and this results into less accurate reduction than in older adults treated with rigid intramedullary nailing. Materials and methods. This was a retrospective study of 56 patients undergoing 16 years with tibial diaphyseal fractures who has treated with intramedullary. 26 patients were treated with flexible intramedullary nails and 30 patients with rigid nails. Clinical examination, radiographic preoperative.
Cases or rigid nail.
Rigid nail. Clinical examination, radiographic preoperative and immediate postoperative and 6 to 12 weeks, and yet the final follow-up were systematically analyzed. The mean follow-up time in elastic stable intramedullary nail group was 12 months and 10 months in rigid intramedullary nail group. Clinical characteristics of the study group. Sir? Rigid nail? No sir. No sir. No sir. No sir. Interlocking nails sir. Interlocking nails. Rigid nails. Sir? Children.
Less than 16 years. That's what it says. Less than 16 years.
Yes sir. Rigid nails and 10 sir. Elastic nails sir. No sir. Interlocking sir. Interlocking. Age of the surgery is 11 years in elastic nails and 15 years in rigid nails, and male are 14 and 24 respectively. Female are 12 and 6. Open fractures are 4 in elastic nails and 6 are in rigid nails, and weight is around 43 kgs in elastic nails and 64 kgs in rigid nails. Open proximal tibial physis in 26 out of 26 in elastic nails and 14 in rigid nails.
Highlight.
Yes. Okay sir, I'll explain. Yes. The way. Yes. Weight of the
PPT is only namesake. PPT means only a point should be there. It requires a lot of effort. It will take at least minimum 2 weeks for making one small PPT of 15 minutes. Even from your journal also.
Yes, three factors are significant. You can just highlight those three factors. That is weight, open proximal tibial physis, age and surgery. Those
Yes.
are significant.
And width of the growth plate.
Yeah.
These
Yeah.
are the three important criteria.
Weight is
Point ekra namaki drive over we chart chuste.
yes.
Okay.
Weight of the patients are more in the rigid nails, sir, and open proximal tibial physis are 26 out of 26 members are from elastic nails used, sir. And operative methods, the rigid intramedullary nail was inserted using the transligamentary approach. Two pre-contoured elastic nails were inserted through the two skin incisions made on the lateral and medial. No, sir. Patellar. Approach, sir. The approach, sir.
Patella is split.
Yes,
Center
sir.
and
Yes,
that is the meaning of
Yes, sir. Sir, wide open physis we used for 10, sir.
Upper end of tibia, it's a tongue-shaped epiphysis tibia. So if you want to do anything surgery, you have to split the ligament patellae and go through that.
In wide open physis, we used to go for elastic nails, sir. In about to fuse,
We
we will
can
go for
about to
rigid nails.
about 13, 14 years. You can go through this.
probably
Maybe is that
it didn't make much difference. That is what I have seen in the conclusion.
right? Right. Okay.
Young children,
Yeah.
only elastic.
Right.
Not through the pipes. So elderly people who
Adolescent,
are
young.
minimal growth,
That's called young adolescent, right?
any difference. That is what
Okay,
probably, that is the driving point.
That's what.
Yes.
Driving point.
And moreover, you should know the epiphysis of the tibia. How is it? At what time it closes? What shape it takes? These are important things to be worried about children. There's always tongue-shaped one which is there, anterior slope is there. That should not disturb any time. Unless it's near 15 years, 16 years, near to the maturity. That's what you should do.
If it is done in a very small child,
Never to do it.
Preservative.
Yes,
You are
Ricardo.
going
Right.
to premature
Yeah, yeah.
growth of the anterior
Yes.
half of the growth plate.
Even that may have some complications. Even at adolescent age, you put it later on if you see, you can get some deformed definitely. So always should be a caveat.
Probably the number
Yeah.
is too small. Here, what we
30,
are
30, 40.
And you said some of the fractures are open fractures and some of the fractures are isolated also. Both you have mentioned.
Yes, sir.
Go to slide, back side one. Isolated tibial fracture 4 for elastic nailing. For rigid endal fixation 6. And open fractures are 4 for elastic, 6 for rigid. So more number of open fractures for nailing.
Yes.
That is the
Right.
indication.
Open fracture, yes.
is an indication. Okay.
Right, so that is important.
And the lateral and medial sides
There
below the
should be a
proximal.
line space between each
Mm.
bullet point. All the
This is
three
something
points
else.
are looking like a paragraph.
Little more down.
And the font size can be reduced so that you get line space.
Medial side below the proximal tibial metaphysis, that is 0.4 into medullary canal. No tourniquet was used during the intramedullary nailing, sir. Results: the mean age of the children undergoing elastic intramedullary nailing was significantly lower as compared with those of undergoing rigid intramedullary nailing. The mean age is 11 years, and 26 patients treated with flexible intramedullary nail and 14 patients treated with rigid nail has open proximal tibial physis. 4 of the elastic nail patients and 12 of the rigid patients have open tibia fractures. 4 of elastic group and 10 of rigid group developed compartment syndrome, requires fasciotomy. Of the fasciotomy, 3 fasciotomies in the elastic group and 8 fasciotomies in the rigid group were performed at the time of the index surgery, and the remainder as separate surgeries, sir.
We are unable to take even a
Anything
single point
from
from
this.
this whole slide. not
Okay.
in a single point.
Is the fasciatum done for open fractures or the closed fractures?
Closed
Rigid
fractures.
nail was there, they had problem.
Yes, sir.
Rigid nail was used, they had a compartment syndrome.
No, sir, they didn't say like this. The
So what this paragraph, yeah, concise, make it precise on this one thing.
Both the groups has got compartment syndrome. 4 for
other fasciatomies, 3 fasciatomies are done in elastic group, sir.
Elastic group.
Yes, sir.
But prior to that, patient had compartment syndrome or just after surgery he had?
After surgeries.
They had.
After surgery.
After surgery, there were 10 out of 30.
10. That is a big number.
30%.
30% is complication only.
Very high.
Yes.
Very complication, right? Complication only.
The procedure should be forbidden.
Yeah, yes, that's what.
30%.
But yeah, is it correct? Now I don't know what. See, the original language of this topic should be Scandinavian, which we don't understand. And while the translating, completing into English, things may go wrong. That's what happens.
In elastic group, an associated fibular fractures were present in 12 cases and 20 cases in rigid nails. The mean operative time is elastic was 1 hour 23 minutes and rigid nailing patients was 2 hours 50 minutes, sir.
Why? Regional patient 2 hours, 15 minutes. 2 hours
Like
is quite a big.
Yes, sir. Median is 2 hours, like the
I know,
middle
but
one.
I don't know. This is small group child, and I don't know why this much time they have taken. Because of this, they had a compartment syndrome. Otherwise,
And they were done without tourniquet.
tourniquet, right?
And
They
if
should
you
not get
do
it.
without tourniquet, chances of
Getting a compartment is less if you
Less.
use tourniquet, right?
with the tourniquet there
Any
is a lot
chance.
of muscle edema due to
Post-op,
accumulation
right.
of all the metabolites. It is directly proportional to the duration of the tourniquet.
1 or 23 minutes is me.
with the tourniquet compartment is high or low?
Hi, sir.
High. So you are doing without tourniquet. Even then you have developed
Yeah.
and the duration of time.
I know, I చెప్తున్నా అదే 2 hours ఎట్లా 2 hours ఇంటున్నా with so much advanced Scandinavian country, they should not have this problem at all. Right.
Treated with elastic stable intermedullary nails, sir. And 3 years follow-up care.
Now, where is the immediate post-op X-ray?
It was not given in the article also. It was not given in the article also.
No, it gives the amount of the growth of the bone in longitudinal direction and the proximal tip of the nail and the distal tip of the nail, how far they are from the growth plate, and
From the fracture
at,
side.
3 years follow-up, how
How
much
good.
of growth has taken place. That gives lot
Yes,
of
yes,
information.
yes.
Immediate
Is it for the
post-op
same
X-ray
patient?
Is a must.
Is it from the same patient? Do not know. Is it from the same patient they have put it here?
And a single bone fracture. This is a single bone fracture. Probably could have been better off with conservative
Yes.
management. Single
Or
bone
what we used to do, sir, we
is
should put a cross pin here.
Child 10 years. Alignment is good. The 75% contact is
Okay,
there.
but all you want to do the cross pin here. That will solve the problem. Right.
That also is not required. Too much of 10
No,
years
but like
old child is left
the
with
gap is more.
another
It's
7
still
years.
simple
Even
for
then
that.
they will unite.
Yeah, yeah. That,
In a child.
you know,
Not in
the
adults.
age ఎంత?
10 years
10
old.
years.
Periostem will be so thick.
Yeah, yeah.
It will be highly vascular. It produces abundant callus
Right. Sir, one more case, eh?
and no sharpening will be there.
Right.
Immediate post-op X-ray is given, sir. For this.
Now, open fracture. This is open fracture.
Open fractures.
Right. So what type of nail is this they have used that we don't have? Is it the solid nail or it is a hollow nail? It looks hollow nail with thick holes here.
Hello.
It's not a solid nail,
Solid.
right? So what type of nail? Is there any name you have mentioned the nail about this? I don't know.
No, sir. Didn't mention, sir.
Can we use V nail here? Function same way. You know what V nail is?
Yes, sir.
You have seen
Yes.
V nail. But there are no holes for that interlocking. This is interlocking can be done. One. Yeah, yeah.
14 years.
Okay, 14 years doesn't matter. 2 years will make.
Maximum growth might have occurred
Yes, sir.
by that time.
And it's a both bone fracture.
Only these two, right?
And it's open fracture.
Yes, sir. It was open fractures. And acceptable post-operative alignment is more in rigid nails, than compared with elastic nails. And delayed fracture healing was seen in rigid nails, and it was 5. And reoperative rate is more in elastic nails, and it was 18 compared with rigid nails.
Why limb length inequality? 8% in ESIN. This is 2%.
Inequality, is it lengthening
Or
or shortening?
not short. All the triangulation is there. Inequality.
Lengthening,
So
sir.
shortening.
Lengthening.
Shortening 5. Shortening 10. Length.
Why is it lengthening?
Sorry, sir, it was shortening, sir.
I was asking you
Shortening more than 5. Shortening more 10. That's what. Lengthening can't happen here. If fracture femur is there, lengthening is you can expect.
Yes.
Fracture femur in children, there can be lengthening even temporary,
Yes.
but not in tibia. Reoperation for what reason? Reoperation.
18, sir,
Infection.
more in.
Infection, huh?
Sir,
Is it reoperation for what?
the removal of the
removal of nail and redo the surgeries is more in elastic nails.
Reoperation means after the union, huh? I don't know what.
for any post-operative complication.
Yes, sir.
No,
Non-union,
sir,
for
non-union.
non-union,
Implant
sir.
removal. No
I don't
specific.
know what this is.
We have to assume that it is implant.
అంతే కదా మేబీ ఇన్ఫెక్షన్ ఆర్ ది నెయిల్ ప్రొట్రూడింగ్ అవుట్ దట్స్ రియాక్షన్
But visit is only 11, those are progress. But visit is only 11, elastic is 18.
రైట్
Reoperation అంటే
అది, that's what.
discussion లో
లేదు సార్, లేదు సార్. mention.
రియాపరేషన్ ఇన్
చేయలేదు
ద సెన్స్ రైట్
for any complication or
Pro-
implant
yeah,
removal
yeah.
is also
Yes.
a reoperation.
yes
Yes.
before union something goes wrong you have to again do it or take it off do something infection is there nail
should-
protruding out
We should remove, sir.
Can it be compartment syndrome also? It can be.
Yes.
Read the footnotes. In the footnotes are on.
Any acceptable post-operative alignment was defined as less than 5% of the angulation in any direction, less than 10 mm shortening, and less than 10 mm dislocations. Varus or valgus angulation of more than 5 degrees, no evidence of 3 cortex union at 16 weeks post-op. Malunion defined as more than 5 degrees angulation in any direction, more than 10 mm shortening, or significant rotational malalignments.
It is hardly possible to judge 5 mm shortening. Very
What?
difficult to assess 5 mm. It can be an error also.
if the fibula is intact it's very difficult to make out also unless fibula also is broken you can have the shortening fibula is intact you'll not get anything at all that's what
There are so many questions to be answered.
the problem is this the Scandinavian country the language they use is different when translating it has become changed everything that's what
Rigid intramedullary nailing at the end of the growth period is not associated with risk of clinically significant growth disturbances. Flexible intramedullary nail does not provide similar control of the fracture alignment as rigid nail does. Elastic nailing is one of the most commonly used fixation methods for pediatric long bone fractures, but it may result in non-union in older and heavier children. Comparison with previous studies. Despite the many advantages of flexible intramedullary nailing, it does allow potential loss of reduction as compared with rigid nailing. In addition, a short period of immobilization is usually needed. In previous studies, the rate of delayed healing was shown to vary by 10%. Gordon et al. Found that patients with delayed union were older, that is 14, then their studies popular.
But is it
as
the same or some difference is there then even otherwise no point in comparison
They have difference, sir.
how much
Age
difference is there
difference.
how much difference the
Elastic
study they
nail
made now
mean is 11 years, sir, and rigid nailing was 14 years, sir.
that's significant
Uh,
okay so show me what we have done here
Sir,
our cases is shown why don't waste time
we
on
don't
this?
have any
Huh?
follow-up X-rays, sir. That's
Doesn't
why.
matter what have you done here. Fracture tibia, so many kids will get it. How many cases you have done in nailing? How many tens?
Like,
Absolutely. నేను చెప్పిన చూడమని. Why to put it? Tens you have done many here,
yes,
right?
sir. Tens many, sir.
Intermediate nail you may not, so you might not done it, but the only thing is that shows some slide. At least those things you can show, no?
Yes.
Intermediate nailing, you tens, only children. What age group you have done here? So many cases you have done here.
Yes.
You not done?
Done, sir.
How many?
Brown et al. Reported a series of 36 adolescents with tibia fractures and open proximal physis treated with reamed intramedullary nailing. There was no long-term complications associated with injury to the proximal tibial physis and no malunion. There was no previous comparative studies evaluating the outcome of flexible versus rigid intramedullary nailing in children with open tibial physis. In this study, rigid intramedullary nailing controlled the fracture alignment significantly better than flexible intramedullary nailing and was not associated with risk of growth disturbances. We hypothesize that adolescents with an open physis may undergo rigid intramedullary nailing as the smooth nail fills the entire entry point through the physis and continuous growth is possible. Conclusion: younger children with tibial fractures who has 50 kgs or less and with proximal tibial growth plate with wide open can treated with elastic stable intramedullary nailing, while more mature adolescent benefits from rigid intramedullary nailing as rigid nail allows more precise fracture alignment without increasing risk of growth disturbances. They didn't mention about this interlock, rigid interlock.
Treating like an adult fracture. Unless they are very badly displaced.
But the type of nail they are not described.
Describes.
Did not name the name. There is the picture it is looking like a regular.
Local injection.
Is there adjustment for your nail?
Yes, sir.
Go back to the clinics. Adjustment clinics. Is there adjustment? Yes. How many degrees of adjustment? It is also not mentioned.
No,
And the entry point also important. For femur, it is usually 2.5 to 3.5 centimeter above the growth plane. For tibia, it is also
2 centimeters
4 centimeter
below the growth plate.
the above and down. Go back to the slope. Hands split, hands tense. And see the distance.
Immediate follow-up X-ray is not.
3.5 to 4.5 centimeters.
What is the percentage of rate of contribution of the growth in the upper tibial growth plate and distal femoral growth?
55%.
The proximal femoral and distal femoral.
Where the maximum growth? Proximal femoral, distal femoral.
Distal femorals. And tibia is proximal, sir.
How much
Proximal is 55%, sir.
Both will contribute, both proximal and distal will contribute. What is the proportion of the
Proximal is 55%, sir. Proximal tibia is 55%, sir.
50?
Distal is
Distal?
45.
40.
40.
Almost equal. There is a general, very easy to remember. 70% distal femur, proximal tibia. 30% proximal femur, distal tibia. Of the whole limb length. Of the whole limb length contribution. So, the reverse is in the upper limb. Distal radius and proximal
Humerus.
humerus contribute 70%, 30% by distal
Distal humerus and proximal radius and radius.
that is reverse. So towards the knee I grow, away from the knee I grow.
Yes.
If you remember the slogan, it is easy to remember.
13 years male with grade 1 compound both bone fracture of left forearm, sir, with left elbow dislocation, sir. Puncture wounds. Sir, Montegia last week discussion. Follow-up X-ray. After follow-up X-ray.
And also Monteja equivalent or variance. So what you done?
Closure reduction internal fixation with tens for radius and ulna, sir.
Elbow?
Sir, we have placed in slab, sir.
Reduced in casualty.
Yes, sir, casual it was stable. It was stable, sir. Yes, sir. Radio capture.
Did you check on the C-arm whether the dislocation was unstable by trying to extend the elbow?
Yes, sir. Checked, sir. It was. It was stable, sir. It was post-operative X-ray also. It was stable, and in CM we have seen, sir. Under CM it was. Yes, sir. Checks.
It is getting re-dislocated when the elbow is extended. That
Best-
usually happens.
Yes, checks, sir. It was. Checks.
Didn't get dislocated.
It doesn't.
Do you have any entry point for this?
Sir.
Where is the entry point for this? Very near to the physis or not? Away from that?
Away from that, sir.
How much?
It was 2 centimeters around.
2 centimeters.
Yes, sir.
Good. Allah? Allah, can we go through the physis or not?
No, sir.
How did you go from there then? Is it through the physis or from the lateral medial side? Nowhere.
None, sir. Middle side, sir.
Medial side or lateral, whatever. It has to go from side. That is the reason. Not to the,
Yes, sir.
not to the physis or physis carpet, good carpet. Allah.
Medial is ideal.
Middle. 72 years, a female with fracture neck of left femur, sir. Is base cervical type, sir. We have done bipolar hemiarthroplasty of the left hip, sir, with cemented, sir.
Age ఎంత?
72 years, sir. Due to age, we have.
Not the only criteria.
Now, osteoporotic looks. Bones.
These are the factors which we are supposed to explain. You can always justify either way or contradict. Is the way in which you justify matters.
Sir, 48-year male with the closed middle third shaft fracture of right femur and grade 1 compound proximal third shaft fracture of right tibia. Sir, ipsilateral. So floating. Yes. Yes, sir. Yes. We are, close reduction internal fixation with ILN for femur, sir. Tibia not done, sir. Internal.
Give that X-ray now. Just what is it? No. Next operative. X-ray, first X-ray. So you say this is a floating elbow. You want to treat this same time or not? If you don't treat, what happens? So you can tell different things. Put it on the cast. How is this?
Yes, sir.
This will mean, you know, how to explain whatever you want to. But is there a need? What are you planning for this?
We have long neck cast applied, sir. Slab applied, sir. Upon
That what? That way it is enough. It's still intact.
If you want to do fixation, what is the preferred method?
plating.
Ipsilateral fracture, one indication is we have to stabilize both.
Yes.
That is the basic principle. So, if we immobilize this, again it is going to become fixed. Because of the quadriceps resistance to the fracture size.
Hmm.
In the femur. One indication, primary indication for internal fixation is ipsilateral fracture.
Ipsilateral.
Whether it is upper limb or lower
Lower.
limb. Justify. Want to leave it like that with conservative management? Why? Is it not operable?
No, sir.
Telling you this thing, then department will
Or you want to perform surgery at a later date?
Later, sir.
Decision
We
has
have.
been taken or not?
Yes, sir. We have operated. No, sir. Within 2-3 days, sir. Plates. Yes, sir.
or there is some abrasion, and the external wound heals, plan for
Plan
internal
fixation.
fixation. Is it plating or nailing?
Plating.
You should have told me all these things before my question. Huh? Why plating?
If you are doing surgery for this also, make it some here. You make put a nail which is there, and then for nail also. The 14 year idea is to fit both same nail with one incision. That's what decided.
But when you are putting the nail, the proximal fragment in the tibia is almost very close to the entry point where you are likely to lateral view. Lateral view. It is likely to get splintered. If you want to do nailing, it is expert nail. Otherwise, biological plating. Biological plating is ideal for such metaphysical fracture. Plating.
Yes.
Hockey plate, locking, 3-4 screws proximally and 3 screws distally. You don't need to open the fracture. Whichever treatment you do, you should be able to justify it. The treatment.
Another is underside 8 mm nail. 8 mm. No much leaning.
And you didn't mention whether it is a single bone fracture or a
Double bone
both bone fracture.
Single ones.
Floating we can do same time or not?
Yes, sir, we can do both at the same time. Retrograde nailing for femur and so depends upon the fracture of tibia, we can do nail or plate. So the same incision.
Suprapatellar nailing.
Twelve is female with grade 1 compound middle third shaft fracture of left femur, sir. It was a puncture wound anterior. Just puncture wound, sir. Puncture. Yes, sir. It was anterior.
No, is it communicating with the fracture or not?
Yes, sir.
That puncture wound.
Yes, sir.
Okay.
Sir? Yes, sir. Yes, yes.
Which is medial, which is lateral?
Uh,
Side left femur.
yes, sir. It is medial, sir.
Punctured wound on the lateral side.
It was externally rotated, sir. It was anterior side, sir. It was.
Can you say has communication with the exterior or not? With the fracture? I don't know. There's something else. You want to be saying anything?
Just abrasions, sir. Superficial abrasions.
There is a medial aspect of the knee joints.
No, sir.
It appears to be going to be a full thickness necrosis.
Moral level. What is moral level lesion? Moral level lesion.
Don't know, sir.
What is moral level? Necrotizing fasciitis.
You get here.
You can get it. You వస్తుందా అది పాయింట్.
Both are same.
No, both are different. Both are different.
Close reduction internal fixation with
Collection of the
Reduce చేస్తాం.
రెండు చెప్పాలి సార్. ఫీమర్ రెండు చెప్పాలి.
close reduction internal fixation with tens for left femur, sir.
What age is it?
12 years.
Can you do the nailing for here?
Yes.
12 years me.
12. Can you
So the rigid interlocking, the rigid intramedullary nailing.
disturb rigid nail? Yeah, this nail for this also.
Yes, sir.
Adults are doing the rigid nails are there. If not, you can use the nail of humerus to his nail.
Femur is a bigger bone compared to tibia and more muscular forces who can enter from the proximal the femur.
Even if you injure the fasces here,
Uh,
only entry point should be different.
Yes.
Not so big. That's what. Entry point was the fasces is quite different.
So what are the three bony point fixations? Where is the three bony point fixation? Where is the 1, where is the 2, where is the 3?
Entry side, sir. Entry, sir.
This side ఏంటి? Three bony point fixation. ఎక్కడెక్కడ ఉంటాయి? Proximal ఎక్కడ, middle ఎక్కడ, distal ఎక్కడ?
Sir, entry and middle at the isthmus, sir, and proximally at the at the entry point, sir, and distal most.
Entry point and fixation వస్తుందా?
Yes, sir.
Then what type of nail is rigid nail? Yes, sir. Intermediate nail, how does it act? Here is different. What you're talking about. The intermediate nail, starting with think of latest one, quite different. But overall, the basic principle in the expansion as well as elasticity and compression. All things are there in this intermediate.
Do you know how to choose the diameter of the nail?
Yes, sir. And 0.4 into medullary canal, sir, or else 70 to 80% of the medullary canal should be filled, sir. At the least medullary, at the isthmus.
80% can be filled.
Yes, sir.
How do you measure the medullary canal? There is a problem with the digital X-rays. It can be
Zoom or
minimized, it can be zoomed. It should be to the natural size of the femur. Then only you can have an accurate assessment. That is the problem with the digital. You can ask them to
Better. Convention is better than this convention.
especially when you are
60 years male with intertrochanteric fracture of right femur, sir. Borden Griffin's type 1, sir. Closure reduction internal fixation with PFN for right femur, sir.
Is it basic cervical or intertrochanteric? Go back. It looks like basic cervical or intertrochanteric.
Sir, sorry, sir, it was some other. It was a
Basic
mistake.
cervical or intertrochanteric? Zoom the image. Zoom the image. Chepu. Is it basic cervical or intertrochanteric?
Intertrochanteric. Intertrochanteric only, no?
Yes, sir.
Intertrochanteric fracture.
Yes, sir.
other one, opposite one.
Sir, actually it was a wrong X-ray, sir. It was.
What is this fracture?
It was basis cervical, sir. Basis cervical, sir. Previous.
Retrochanteric is involved.
No, sir.
Sir, that fracture not belongs to the
Yes, sir.
this patient. This is a different one.
Is it from the same patient?
No, sir. No, sir. No, sir.
So no, sir, this is the previous one. That hemiarthroplasty done. That
Actually, it appears it is not done in the internal rotation today. This is in complete external rotation, and it appears there is an intracapsular fracture. Because of external rotation, the calcar is not visible, and there is overlap of the head and the neck in the superior part of the head. It has been taken in an external rotation. It could be purely intracapsular.
Sir, PFN. PFN.
ఈ పేరేంటి? ఈ పేషెంట్
సత్యనారాయణ
సత్యనారాయణ. అది
పెంటమ్మ
కంటమ్మ. 72 ఫీమేల్స్. ఇది ఎంత? PFN ఎంత ఏజ్? PFN is 60 years.
ఎస్
That left one is already operated.
ఎస్ సార్
What was
ఆల్రెడీ
the
డిస్కస్డ్
finding under CM? What was done for her?
హెమియార్థోప్లాస్ట్ బైపోలర్ హెమియార్థోప్లాస్ట్ బైపోలర్ హెమియార్థోప్లాస్ట్ బైపోలర్ హెమియార్థోప్లాస్ట్ సార్
When it is basal, why did you do anti?
ఇదే
That was not properly studied X-ray.
సార్ 60
Sai Pradeep Reddy. Last time ఒకటి ట్యూమర్ కేసు ఉంది కదా. Recently, what is the report follow? Biopsy report.
దిస్ సెకండ్ ఇస్ సెకండ్ ఇస్ ఫ్రమ్ థైరాయిడ్ ఆర్ లంగ్ అని ఇచ్చాను సార్ ఎస్ సబ్ట్రోకంట్రిక్ ఫ్రాక్చర్ ఉంది సార్
Pathological fracture.
One with the long PFN. Long PFN కదా.
ఎస్ Secondary is
Thyroid or
lungs. Yes.
lungs. Yeah, no?
Okay.
In those cases, you have to go to molecular studies. That is important. In those cases, it needs a molecular study.
Sir, 16-year male. 16-year male with 7 weeks old fracture neck of left femur, sir. He is walking with pain, sir. Yes.
X-ray quality is very poor. One more X-ray there. Not seen. Assume that head and neck. Immediate fresh case or very
7 weeks old, sir. Late presentation. Yes. 7 weeks, sir. With pain, sir. Yes.
impacted abduction. See, head is in valgus.
Yes.
Head is almost near vertical.
Yes.
The lower S-shaped line
Loss.
and the Gordon's index. Have you read that X-ray in those directions? If you read this X-ray in that direction, that's Lowell's line and Gordon's alignment index. Did these 2 points come to your mind or not?
Gardens.
Awesome, Veda.
Yes.
What is the purpose of these? These are all the things Jubilee Teaching Institute, we always keep telling Lowell's lines, Gordon's alignment index and the trabecular pattern. And it's already uniting, half united.
So, we have done MRI, sir. Yes, yes.
And had you left him like that, you could have walked without much another 3-4 weeks. Sometimes these fractures go unnoticed. They will have some pain, a little pain, bearable pain. Few weeks and then they become normal.
We have done MRI, sir. Yeah.
Why MRI?
Any avian. Partially.
Do you expect avian changes to take place?
No,
Why
sir.
is it done?
You.
Healing. CT will do better understanding about healing, not MRI. Avian doesn't happen in 6 weeks.
4.
So MRI has no indication here. Lakshmikant, MRI advised.
It will take at least 3 months to. It will take at least 3 months to even the changes to be seen.
Was it advised
No,
that
sir.
somebody
If you take avian changes, you have to wait at least for 6 months, 3 to 6 months. So establish a non-union declared intracapsular fracture neck of femur only after
3 months. 3 months.
after 3 months, thinking that it is going for, by all practical purposes, it is going for non-union.
None.
next.
We have done closed reduction internal fixation with CC screw fixation. One screw with the washer and
So once you have done this, then you may go into avian. Who knows?
Long-term follow. Follow the case for 2 years.
yes.
Premature growth arrest.
And idiopathic osteochondrolysis. What is the other
So
patient?
there is
16 years.
controversy whether the threaded portion should cross the physis
Physis.
or should not cross. There is a lot of, some people say threaded portion should engage the
Physis.
growth plate, threaded portion. Some say should not engage. But to keep the threaded portion should engage the growth plate so that it doesn't produce compression and premature growth arrest. Yes.
And there is one more study of fully
And
threaded.
the moment the fracture has healed reasonably well, they should be removed.
Yes. Okay.
And you go.
When do you want to remove this? Problem is this, you do a surgery and left there and we come out of it's a broken implant. That's problem out there. The best thing is once you tonight,
Then remove.
we have to next follow-up they'll come in, no problem. That's a broken. I have two patients now where this is broken inside, this is broken inside.
Okay, next.
In these cases, ideal, that's up. Go back. In these cases, ideal is PCCP. Percutaneous compression plating is ideal. Screw construct is different from screw and plate. Cantilever plate is better.
And already more than half united. Whatever you put or you don't put also, it will not cause any problem. Okay.
44 years male with intertrochanteric fracture of right femur, sir. Body graph is type 1, sir.
Important, sir. There is one more point, sir. Fully threaded versus partially threaded.
We have done closed reduction internal fixation with PFN for right femur, sir.
Next.
20-year male with closed second metacarpal fracture, metacarpal head fracture of right hand. Sir.
Zoom jab, sir. Film zoom.
This. Yes. Head fracture.
Right hand. Now knee.
Can you repeat conservatively this one? The implant is put it back on the head.
But
This is cut.
yes.
Right it.
Yes, sir. Okay. We have done open reduction with the K-wire fixations.
You are there for surgery.
Yes.
How did you go? How did you do the joint?
We done incision on dorsal over a joint. Sir. Split, yes. Yes.
You should not denote is the sensor.
You are flexing the empty joints. That's all. Next.
Morning, sir. This is a 23-year-old male with closed middle third shaft fracture of right femur, sir. We have done closed reduction and fixation with, sir. Here, middle third distal third junction is there, sir. Sir. We have done closed reduction and fixation with the interlock nail, sir. This is 37-year-old male with a grade 2 compound middle third shaft fracture of both bones of left leg. We have done closed reduction and fixation with ILN along with the wound debridement. Sir?
What was the nature of the injury?
Uh,
This is what manual extremity disease. Run over by something is object which is in the mind. Is it completely the tissues and life
Not between two hard objects and then twisted.
mangled limb, this is what.
okay, sir. 32-year-old male with closed medial malleolus fracture of right ankle. With an open adduction. This is a supination adduction type of
Medial malleolus, ఇంకేం చెప్పక్కర్లేదా?
with
Is it common to have only one manual fracture?
isolated it is rare, sir. Usually lateral malleolus will also be included. This is isolated medial malleolus fracture, sir.
Possible to have only isolated one or not?
Yes, sir.
Always some ligament injury is there. Anterior, posterior, lateral, medial.
Possible, sir. Isolated medial malleolus fractures are possible, but rare.
We'll leave it, what happens? I'll put a cast. Cast in varus. Cast in varus. Short like cast, let him walk 2 nights.
What is the indication for surgery? Sir is telling I will
Sir.
treat it with manipulation of block.
It is including the as it is including the joint. Rigid fixation is important, sir. As it is including the joint, rigid fixation is important. Ankle joint, sir.
Okay,
Yeah.
it's for all practical purposes, it is an intraarticular fracture.
Sir.
Is it the indication or anything specific for this type of medial malleolus? What classification is it?
This is supination adduction type of log Hansen classification, sir.
Supination,
Adduction.
adduction.
Yes, sir.
Where did you say adduction?
Here there is a vertical fracture. Is this almost near to? It is little oblique, but oblique is there.
Practical purposes, it's an abduction type of violence because there is a opening of the fracture, even significant opening. This is not vertical. It's an eversion. Eversion means pull off on the
Dead lots.
medial side and push off the neck.
See, you can see the gap here also.
The force of violence stops at one particular level.
So
Then it is only the medial side that gets failed and lateral malleolus is intact. And whether it is associated with iliofibular syndesmotic injury or not, you are supposed to take stress x-rays. Mortis. So if there is a tear in the supination external rotation injuries, there is a tear in the FRCS ligament that also should be addressed.
Not looking over, but this gap you can see made also. Move here. Here move like this.
So what is the right side view?
mortis use.
Is not a true mortis view because you are not seeing the true fibular and talar articular joint space. It is not true mortis view.
Yes.
How to take mortis view?
With flexion.
What is the position of the joint or the limb?
With flexion and internal rotation of the foot, sir. With flexion,
Flexion.
plantar flexion and internal rotation of the foot.
Flexion where?
Plantar flexions
Why plantar?
to expose the ankle mortis joint.
15 to 20 degrees of internal rotation of
Yes,
the limb. 20 degrees of internal rotation. That will open the syndesmotic joint also. Okay.
When
Whether the talar body has shifted or not in the syndesmotic view or even here, the medial margin of the distal tibia and the lateral margin of the lateral margin of the distal tibia and the lateral margin of the body of the talus, they fall in a line. If it is moved outwards, they don't fall in a single line. That line with the distal tibia is called as incisculum. These are very, very, there will be so much of detailed radiological description for reading the ankle joint like radius, distal radius. Because if you don't know these minor points, you will miss so much of variations.
Open injection with malleolar screw, sir.
So what is the indication for surgery?
You did not answer the most important crucial point. That is the point
Sir.
for indication for surgery. What, were you there?
Yes, sir. Yes, sir.
What was the observation when the practice site is open?
Anything inside between the fracture fragment? Is there anything between the fracture fragments?
No, sir.
Nothing is there.
Soft tissue intubation. That is periosteum, sir. Periosteum.
Indwelling of the
Yes, sir.
periosteum.
Observe చేసావా?
Sir. Yes, sir. Yes, sir.
వాళ్ళు చెప్పారా?
Yes, sir.
చెప్పారా?
Yes, sir.
మరి ఎందుకు చెప్పలేదా పాయింట్? After treating conservatively, it is likely to fall into its anatomical position. But even then, the fracture fails to unite and results in non-union. If you take an X-ray at the end of 6 weeks, because
Periosteum.
gets infolded.
Yes.
Periosteum always gets torn along the fracture line, and it gets opened up when the talus falls in it back in its position in the mortise. The periosteum which is torn from the distal fragment, it gets infolded. Infolding of the periosteum acts as a soft tissue interposition. So such fractures, it is mandatory to open it up, clear the periosteum, and then fix it.
Yes, sir. No, sir. For crisscross gives more rigid stability.
If the fragment is small, when you drill and put the malleolar screws, the head is too big.
Yes,
It is likely to splinter the small fragment. Here it appears to be fairly large fragment.
yes, sir.
But sometimes if it is too small, the fracture line is horizontal at the level of the joint line. If you put 2 screws,
Yes, sir.
it's splintered.
Yes, sir. Sir. Yes, sir. Yes. Proper fracture reductions. Yes, sir.
What are the indications for screws? What are the indications for tension band wiring? Tension band wiring also is indication here. Which is preferred? If the fragment is too small, tension band, because the amount of damage to the small fragment is minimal, K-wise. Tension band wiring is ideal for a small fragment. These fragments may be, 2 screws may not be essential. One malleolar screw and one K-wire. One K-wire that acts as a derotation. K-wire acts as derotation. 2 acts as a, what is the principle of fixation here?
Angle.
What is the principle of the screw fixation for this fracture?
Articular surface.
No,
To get the articular surface and I mean congruency, sir. Yes,
no, no. What is the principle?
Compression, distraction, compression, sir.
Interfragmentary compression or like that? The lag screw or
Lag screws. Yes, to get compression at the fracture side.
What do you mean by the lag effect?
It distracts and compresses at the fracture side, sir. It maintains compression at the fracture side.
Why? How does it produce compression?
It creates distraction along with it.
smooth portion of the screw are different. When the diameter at the practice size of the screw is less than the threaded portion, it is a loose screw at the practice site, so that when the screw is tightened and the near fragment gets compressed against the far fragment, thereby producing compression. That is what is called as a lag effect. The diameters are different between the shaft and the threaded portion. That is, suppose you don't have malleolar screw, you have cortical screw. Can you achieve the lag principle with a fully threaded cancellous screw?
No, sir.
You can't.
No.
Can anybody answer? It can still be done if you don't have the lag screw. You overdrill the near fragment, overdrill, so that the threaded portion will be lying loose in the near fragment, and the far fragment will have a good grip with the threaded portion of the screw. The near fragment should be over-drilled, so that the threaded portion in the near fragment doesn't have hold. So if you want to make use of a fully threaded screw and
Over-drill.
fully achieve lag effect, that is the principle.
Over there.
Eighty-year female with intertrochanteric fracture of left femur. It's Boyd and Griffin type 2.
Do you know this principle of using a fully threaded screw, cancellous screw, and still achieve lag effect? Huh? Why don't you come and answer? I know ఆయన కే పగిలింటేదా తెలుసు కదా ఏం చెప్పాల్సింది హౌ టు బిలీవ్ బట్ యు నో ఐ డోంట్ బిలీవ్
చెప్పడం అలవాటు చేసుకోండి, ఎగ్జామ్లో చెప్పాలా. సో రెస్ట్ తీసుకుంటారు సార్, రెస్ట్ తీసుకుంటున్నారు సార్, రెస్ట్ ఆఫ్
A 80-year female with intertrochanteric fracture of left femur. It's Boyd and Griffin type 2, sir. We have done closure reduction internal fixation with long PFNs. 26-year male with 3 weeks old closed comminuted middle third shaft fracture of left clavicle. It's group A, sir, Allman classification, and it is a vertical fragment was present, sir. It impinged, sir. Yes, sir. Yes, sir. Behind the clavicle, brachial plexus injury was, and subclavian artery also present, sir. Yes, yes. Yes. This vertical fragment impinges the skin, sir. This was the clinical picture of the patient. Denting of the skin. Yes, sir. We have done open reduction internal fixation with 7-hole clavicular blades, sir, with interfragment risk. Sir? Superior to the clavicle. Yes, sir. Yes, sir. First inside the skin, sir. Then platysma was present. Then periosteum.
There are no nerves here, no nerves supply in this area.
Supraclavicular nerves was present.
No nerves are here. The common challenges people have is once due to this, because there is a lot of pain in this area. Where there is a subcutaneous level, you have cut the nerve, that definitely will come down. So be very careful with this. Avoid this, cutting of this subcutaneous nerve which come across from here. That's one. Doing surgery is not a great thing, it is great. If you have a few other complications come across, and the patient is made, avoid all these complications.
Okay, sir.
Sir, you have used a interfragment tube
Yes, sir.
putting the plate? Yes.
After putting the plate.
After putting the plate, interfragment.
Yes.
Particular, no. Go back. Did you stabilize the initial cable or not? How did you do it?
Initially we stabilize the KY, sir. After that we putting the plate and.
Unless you stabilize with this and later on assemble all these things and put a plate over there.
Yes, sir.
You should have taken an intraoperative system scale.
Okay.
Stabilization plus reduction, stabilization. X-ray is done post-operatively. Why not only the left side clavicle and shoulder?
Comparative
Including the opposite shoulder.
comparison purpose.
Why should you compare the opposite shoulder? Is it a hip joint to compare the opposite?
No.
Then why? It has become routine here in FCS, even for civil,
Yeah. If you want to
simple
do
surgical neck
shoulder,
shoulder.
come to sit down. Here shoulder is what is
అది ఎందుకు అట్లా not required.
but reaction is required. Suppose something goes on lunch, it will make out.
Length restore.
Extension flap or
Length of the clavicle restoration.
length of the clavicle.
No, the leg is not restored, what happens here? Fracture clavicle. Then overlap will break this part. Overlap and separation. Fracture right leg. Very shortening of the clavicle. What's coming here? Example. Fracture clavicle you have treated or not treated. The united this overlapping is there. Shortening is there. What are the complications here? What is even the patient will have?
This more than 2 centimeter shortening is one of the indication for surgery. So what happens when
Patient comes with this overlapping of this much shortening is there. And what patient from no pain is there. What are the disability the patient will have? Because the minor legs. The chest marker doesn't matter. Man labor,
Abhinav.
always maintain here. Shoulder and middle side of the maintain. Otherwise, mechanical advantage to do work from heavy work. So always try to maintain this. Legs should always see.
Shoulder girdle, femoral girdle.
So these are the cases and
Joints associated with shoulder. What are the joints associated with shoulder? Example.
Shoulder joint include what? Which shoulder joint?
Clavicle.
All the joints are there. Shoulder girdle.
Shoulder girdle.
Includes what?
Shoulder girdle.
Example for us. Example.
Glenohumeral, scapulothoracic, including sternoclavicular. Orthoclavicular, of course. Acromeclavicular also. What is importance of glenohumeral versus scapulothoracic? What is the importance of glenohumeral versus scapulothoracic?
These are the cases in Unit 2, sir. 6 years male closed supracondylar fracture of left femur, sir. Yes, sir. Yes, sir. Closed.
is it extension type or
Extension
flexion type? Classification.
Atlan classification extension type type 3.
Uriye supracondylar ante supracondylar. ఇది flexion type ఆ extension type ఆ? Extension type అయితే
Type 3, sir.
దాంట్లో ఏ type?
Type 3, sir.
Classification
Type 3, sir. Displaced. No, sir. Displaced. Fully displaced.
there is intact, there is contact.
Even of the manifestation still is
No, sir. Type 3. Extension.
So when there is no contact and zero contact between the proximal and the distal fragment, 3A, B. Here there is contact.
Try to reduce, sir. Yeah. We have done open reduction, internal flexion with K wire.
What did you achieve here? Nothing. This still the bed is still here.
Zoom the elbow with KY. Zoom the elbow with KY. Again. POB.
Yes.
Why do you keep quiet? You must discuss in the OP.
So anterior humeral line should coincide with the capitulum, sir. And should cut through.
Anterior humeral line cuts through the cuts between anterior 2/3 and posterior 1/3 of the capitulums. Anterior 1/3
Anterior 1/3.
and posterior 2/3.
So here I have shown you clearly this is the full width of the distal fragment and this is the full width of the proximal fragment. This posterior K wire has gone through the fracture site, opening up the fracture, and it appears apparently that it is aligned, but if you draw the anterior humeral line, the distal humerus is posterior to the anterior humeral line, and the width of the proximal and the distal fragments are disparity is there. That means there is a rotational deformity. So there is no proportional width. It indicates that there is a rotation. Invariably, it will be an internal rotation. Another thing is, draw a long axis of this distal fragment and long axis of the shaft. There is a anterior convex. See this? This is the long axis of the distal fragment. This is about 15 degrees of hyperextension. This is a hyperextension. In supracondylar fracture, it is called as a straight line deformity. One is the varus, another is the hyperextension, and third one is internal rotation. These are the three components of the malunited supracondylar fracture. So you have improved the position, but not the rotational deformity. So this is very important, which is more responsible for the upward construct deformity. This hyperextension may not be of great importance. Okay? Internal rotation is the one that should be prevented. Here it is, you see this is overlapping. It appears as if it is aligned. Just spurious. Okay. X-ray slightly medially displaced. See again, very clearly seen. So much of it here, and this is the true laterally of the distal fragment. It was so thoroughly discussed 48 hours back. In the OP. You are not remembering the discussion.
Is there any rotation deformity?
Where, sir? Is there?
No, previous X-ray.
Is there? Is there, sir?
Rotation deformity. How do you know there is a rotation deformity?
Width is different.
2 minutes lo much for
Okay, sir. Go ahead, sir.
This is 16-year-old male with both bone shaft fracture of left forearm, sir. We have done open reduction and internal fixation with 16, sir. The boy is epiphysis. Epiphysis. No, sir, no. Epiphyses are not closed.
What time they fuse?
Bone was also thin.
How much of width of the growth plate is left behind? That is an important point to be looked at. In another 1 year or so, probably he will have skeletal maturity. Almost like an adult, he can treat him like an adult. 16
Which is
years.
better, both are going to fix the nails or the plates?
Plates.
Right. Why not nails?
By all practical purposes, both bone forms should be considered intraocular fractures. So, anatomical the reduction, rigid fixation, and early mobilization.
That is only with plate, not with nails.
Only in small children nails.
So, why didn't you go with plate?
With nails.
Lesser.
No dissection.
No,
Closed nailing.
hematoma disturbance is not there.
Closed nailing.
We do not disturb.
Surgical morbidity is negligible.
Soft tissue involvement is less.
Implant removal is easy.
Is
3 points. Okay. But you have to immobilize the limb. That is the disadvantage.
yes.
No more X-ray.
No, sir.
Still 6 cases are pending. 8 cases. 6 cases are pending.
7.
Sir, exam ongoing, sir. Will going ongoing.
One more point. Show the X-ray of the metacarpal fracture. Cancel there. Zoom date. Here, there is one more method of visualizing these fractures. It's almost like an intraocular fracture. If the fracture is around the neck area, then it is elevated. To treat it conservatively without margin is difficult. So instead of tampering with the extensor mechanism or later to the joint or the capsule or the ligament, you can make a small drill hole here, cut a KY and bend it slightly at the tip, cut end for about 2 millimeters or 3 millimeters. So introduce the KY from the base of the metacarpal and then after reduction under C-arm and drive the KY almost up to the subchondral bone so that you will be able to start the movement of the finger immediately after surgery. Here there is a very likelihood of stenosis of the extensor expansion or likelihood of injury to the neurovascular condition.
Here the MPJ is okay.
Here of course.
That is nothing happens. You just try to go there.
But can be prevented if the fracture is a little distant. Of course, cross skinning is always stable incision.
కేస్ ప్రింటేషన్ రాలే మీరు మొన్న ట్యూస్డే కేస్ ప్రింటేషన్ రాలే